Good morning, good afternoon, good evening, wherever you are. Welcome to Virtual Grand Rounds. This week, it's a great pleasure for me to invite my colleague, Professor Nicholas Hopkinson, who's part of the National Heart and Lung Institute at Imperial College, who's going to give us an update on bronchoscopic lung volume reduction. This couldn't have been done without the generous support of our sponsors, which is AstraZeneca, Medtronic, and Medela, the Science of Care. Over to you, Nick.
Morning. Thanks for the invitation, and thanks everybody for giving me your time. So I'm going to talk for 15 or 20 minutes about bronchoscopic lung volume reduction and how that fits into sort of clinical pathways, sort of more broadly, and talk about a little bit of the research that we've been doing in that area. Just to recap very briefly, the problem with emphysema and why lung volume reduction is a good idea is that the bad lung in people who've got emphysema just gets in the way. So in emphysema, of course, the lung is more compliant. It's floppy. It's useless. When a person breathes in, the damaged abnormally compliant lung will expand at the expense of the healthier, more elastic lung. And you can see sort of an extreme version of this on the CT scan, where obviously the oblique fissure is not passing obliquely across the middle of the picture. It's all the way down with the either compressed or sort of closing under its own elasticity, healthier lower lobe as the upper lobe, which is largely emphysematous bullae is expanding. So that means firstly that you have that the person has a lung full of useless air that is not contributing to gas exchange, so they're having to breathe at a higher lung volume. If they're already starting at a higher lung volume, it restricts their inspiratory reserve volume, how much further they can breathe in when they want to increase minute ventilation. The diaphragm is flattened, so it's at a mechanical disadvantage, and the muscle is shortened, which impacts on the length-tension relation of the muscle. The inspiratory load breathing at this higher volume is higher. There's a greater proportion of ventilation as dead space, and the healthier lung isn't able to get involved with gas exchange, so that sort of worsens things as well. So that's the problem physiologically. It makes a difference to how people with COPD, of course, live their lives. That makes them breathless. The figure on the left shows the impact of hyperinflation assessed as the inspiratory capacity as a proportion of total lung capacity. It shows that if you have a less than 25% inspiratory capacity left, then the mortality rate is much higher. But again, it's not just physiology, it's not just survival, it also impacts day to day. So the figure on the right, which is a plot of another measure of hyperinflation, the residual volume as a proportion of total lung capacity, and that's plotted against physical activity measured as daily step count. And as you can see, as the degree of hyperinflation increases, the daily physical activity changes. So this is obviously something that matters. Now, the first slide introduces the concept that there is bad lung, and there is clearly a surgical approach to that, which is to take it out and put it on a piece of sort of pale bluey green towel, so it's no longer inside the chest. And lung volume reduction or reduction pneumoplasty is a very well established, very effective treatment to improve the quality of life and survival of people with emphysema, providing that those people are appropriately and carefully selected, and that we owe our confidence in that, both to daily clinical experience from doing these procedures within the context of advanced COPD MDTs, but also particularly from the NET study, which showed in people with upper lobe predominant emphysema and a reduced exercise capacity that there was a survival benefit with lung volume reduction surgery compared to medical management. And because there was no crossover in the study, it was possible to make confident statements a very long time after the actual surgical intervention, because no one in the medical arm went on to get surgery. So we have this as an effective treatment already. Understandably, because thoracic surgery is an invasive procedure. There's certainly risk associated, there's costs associated with it. Other approaches have been considered, and endobronchial valves is the approach I'm going to be talking about a little bit this morning. So this idea is that rather than resecting the target area of lung, valves are placed into the airways with a bronchoscope to target the worst affected lobe of the lung. So they're placed with fiber optic bronchoscope, and the target lobe, if it can be completely occluded, the air in that is resorbed and the target lobe shrinks down. So you haven't taken the lung out and put it in a bucket, but it's still inside the chest, but it's not occupying any space, or it's occupying much less space. So the level of hyperinflation goes down. Now, this will only work if there is no collateral ventilation between the lobes. So essentially, if the emphysematous process has broken down the interlobar fissures, the air when the person breathes in, even though air can't get to the target lobe through the airways, there are lower resistance pathways that that air can still get into the lobe by going in through the adjacent lobe. So essentially, nothing happens. The main sort of complication of valve placement is pneumothorax. So as the target lobe shrinks down, the rest of that lung will remodel, and that can cause small tears in the lung, or this sort of pneumothorax sort of vacuo as the configuration of the lung changes. So just to sort of give a nice example, you can see the image. These are obviously two CT scans of someone with severe emphysema. You can see that the left lower lobe in the left image pre-procedure is shows very extensive emphysema. There's virtually no healthy lung there. Following the placement of endobronchial valves, that lobe, which you can just make out posteriorly on the right image and at the back of the left lung, you can see that there's been complete atelectasis, and the size of that lung has shrunk. You can see the midline has come across, and there's now healthy or healthier aerated lung instead of useless emphysematous lung that is not contributing to gas exchange and also making the basic ventilatory process more difficult. Ooh. I've forgotten I had arrows, but I'm sure everyone watching can hopefully see the difference there. So as I said, this only works in people where there is no collateral ventilation between the target lobe and the adjacent lobe, and that can be assessed basically in two ways, three ways, I suppose, is put the valves in and see whether they work. But the first way it's assessed is radiologically. It's by looking at the interlobar fissures and establishing whether those are sufficiently intact for it to be reasonable to try endobronchial valve placement. And the second is by direct measuring it using a pressure and flow catheter. So the balloon's inflated into the target airway. There's a pressure sensor and a flow sensor. So you can see on the top image here, which is recorded over about 4 minutes, you've got a pressure sensor. So that's the blue line going down is going down each time there is a breath in, and the sort of yellowy brown image at the top is recording flow. And when the valves are first placed, obviously the target lobe contains air, so as the person breathes, that lobe slowly empties until there's nothing more coming out and the flow disappears. Now, if there is collateral ventilation and the lobe is getting a new flow of air, a new supply of air, then that flow just continues as the person breathes, and that person is CV positive. And the evidence, by and large, seems to be that where the measurement is sort of indeterminate and it's not possible to get a measure, you tend to get a bad outcome as well. So people really need to be CV negative before going ahead and placing valves. So I obviously showed you the NET study, which shows an improvement in survival. In a sense, if you can improve survival, then obviously a lot of other stuff you can take for granted must be happening as well. The evidence for endobronchial valves comes from a number of randomized controlled trials. It's one of the largest ones, the Transform study. And you can see that there's 3 lines in each of these figures. The standard of care group, the control group in yellow, who show a deterioration, for example, in FEV1 over 6 months. and the endobronchial valve group in blue show improvements, and the green line is the difference between the groups. So you can see that in this randomized control trial, you get an improvement in FEV1, you're getting an improvement in 6-minute walk distance, a reduction in residual volume, obviously because it's a lung volume reduction procedure, and also improvements in quality of life as well, which are well above the minimum clinically important difference, so which is 4, and you're getting an improvement of about 8 points, albeit it's not a blinded study. So and we can assemble the data from trials, and we now and be confident that we now have 2 effective lung volume reduction procedures. We've got surgery, and we've got endobronchial valves, which all improve lung function. They reduce airflow obstruction, they improve walk distance, they improve quality of life. The valve treatments comes with this roughly 25% instance of pneumothorax. So the practical approach to that is to keep people in hospital for typically 3 nights after they've had the procedure. Obviously, managing a pneumothorax for someone who's in hospital is a lot more straightforward than if they're at home. A lot less drama and anxiety. So that's the way of making this something that can be done safely and practically. So one of the questions is, which procedure should people have? We know from that, as I've said, because you had no crossover, so we have a very long follow-up of people who either were or not treated, that there's a survival benefit. The early work in valves, before we properly understood about the importance of collateral ventilation, shows that essentially if you put valves into people who have collateral ventilation, then nothing happens. Whereas if you put it in those without, then you get lung volume reduction. So it's possible to sort of do this by looking at the people where the treatment is effective, so where there is atelectasis or where there is not. And this is follow-up data just from our the first case series we published in the Lancet back in 2003 now, 22 years ago, showing that the group without atelectasis, the lower survival curve, died at roughly the rate that you would expect people with that severity of emphysema to die, whereas there was a very prolonged survival benefit in the treatment arm. So the 5 who had radiological atelectasis, that they all survived out to 7 years, in fact. So a very impressive difference. Much larger study looking at a German registry population, again compared people with atelectasis to people without, and shows again a survival benefit in people where the treatment has worked. And that's what you would expect in people with COPD who are fated to die from respiratory failure. Effectively, if you reduce the gas trapping, you're essentially turning the clock back on that process, the same as with surgery. So there's a whole separate talk about the way that people with COPD actually experience COPD and why it happens. And for anyone interested in it, there's a paper that we published in the Blue Journal last year with Paris Williams as the first author, looking at the way that COPD is something that is actually is caused by social structures, and then the systematic diagnostic delay, inadequate care. The condition has a low status compared to other medical problems, and people have to live their lives with COPD without the support that they need. And one of the reasons that I've been interested in this is because spending the last essentially quarter century trying to provide specialist care for COPD, you come up against the fact that basic care for COPD is often absent. And this is a quote from a patient in some qualitative work that we did around emphysema treatments and around lung volume reduction pathways. And it was essentially they had to fight to get a referral. So the system was not delivering this treatment to patients. They needed to find out about it through whatever channel, and the referrals were quite random. Certainly in the UK, we now have got to the situation where there is specialist clinical commissioning for lung volume reduction procedures, either surgical or bronchoscopic. So that is an enormous step forward to making sure that this treatment is available systematically for appropriate people with emphysema. But it's one thing for it to be acknowledged in that way, and for there to be a funding pathway in that way. It's another thing for it to actually happen. And again, we need to make basic care of COPD more effective. So, having been approved by NICE as an intervention, as lung volume reduction procedures, having been approved by NICE as an effective and valuable intervention for people with COPD, so that you are getting a treatment benefit, and also the cost per quality adjusted life year, the health economic impact of it was satisfactory. One of the questions is, how do you operationalize that? So the approach that NICE and that we've been promoting and try to operationalize is tying lung volume reduction very much into pulmonary rehabilitation services. So for a patient with COPD, at the end of a pulmonary rehabilitation program, you would expect their medication to have been optimized. They are as fit as they're going to be. They should know how to manage their own condition. And if at that point they have severe airflow obstruction and they are still limited by breathlessness, there isn't anything else that's going to come along conventionally to improve that. So they're the best they're going to be. And that's the point where somebody needs to think, can this person have a lung volume reduction procedure? And the way that this has been developed is to think about a sort of three-step pathway. So at the end of pulmonary rehab, is there severe airflow obstruction? Is the person limited by breathlessness? Have they quit smoking? Are they someone who is not so limited that their exercise capacity is so low that it wouldn't be safe? And at that point, the message that this person should be considered for a possible lung volume reduction needs to be fed back to whoever's referred them for pulmonary rehab in the first place. Now, their response should be to get the person a respiratory review that establish A, are they hyperinflated, and B, do they have emphysema, and C, do they not have contraindications? So someone with the respiratory should conduct a respiratory review to say, is it plausible that this person could have a lung volume reduction procedure? And then if it is, at that stage, a lung volume reduction MDT needs to actually go through the technical questions. So you have a sort of three-stage approach, which should funnel only the appropriate and also optimized patients to the MDT service. And we've developed a decision support tool that goes with this, which essentially is a tick box that's been developed with pulmonary rehab programs and supported by Asthma and Lung UK, which produces a series of texts and also links to patient information and healthcare professional information about lung volume reduction. Now, the really essential thing about this is it does not require the pulmonary rehab service to know anything much about about lung volume reduction at all. It's not about making everybody in the pathway an expert. It's about thinking, what do the people at each stage need to know in order to help appropriate patients get to where they need to be, which is, for some people, lung volume reduction, and for other people, nowhere near that. You can obviously express this in a much more complicated way in terms of referrals to service. Everything on the right in blue is the sort of workup, evaluating patients, particularly thinking about multimorbidity. 50% of people with COPD will have 3 or 4 more other long-term conditions, all of which leads up to this MDT discussion. And at that, you have a sort of set number of possible considerations. There's no LVR option. They might be suitable in the future, but they're not severe enough, for example. Are they suitable for valves or surgery, or both? Where the answer is both, again, we come back to the question of which. So we've seen evidence to show that there are improvements in important clinical characteristics, and probably in survival with valves, and definitely in both of those things with surgery. So you're starting with people who've got severe COPD, they're limited by the breathlessness, hyperinflated, emphysema, they don't have contraindications, particularly sort of lung fibrosis. And so the next question is, what makes you decide which treatment? So there's collateral ventilation. If there's collateral ventilation present, the valves won't work. There are anatomical considerations. I mean, these obviously are considered on a case-by-case basis, but obviously an endobronchial valve will take out, or endobronchial valves will take out an entire lobe. So a hypothetical part of the lung where half of the lobe is completely destroyed and has huge bullae in it, and the other half is quite healthy, it may be better to have a surgical approach that takes out the bad bit and leaves the good bit behind. Also, in the other issue sometimes is pulmonary hypertension, where the risk appetite is a little bit different for surgery and for valves. That I think is always an exception in general. If people are fit for lung volume reduction, they're fit for lung volume reduction, surgical or valves, and valves are not generally a treatment for the worst patients, because you have to be well enough to survive having a pneumothorax, for example. So the starting point is that there's sort of equipoise. Both of the treatments are probably effective, and we have conducted a randomized controlled trial where we took people that the MDT did feel were suitable for both treatments, and they went on and had a charted procedure, and if they were CV negative, they would then be randomized to either valves or to surgery at that point. And we had 12-month follow-up, and the primary endpoint was the iBode index, which is basically the Bode score, but with an incremental shuttle walk test instead of the 6-minute walk test, uses the exercise test. And not to go through all this in detail, but ultimately we randomized 88 people to surgery or valves, and at the end of it, who were sort of mean age 65, severe to very severe airflow obstruction, shuttle walk distance of about 200 meters, with severe symptoms, so CAT score in the 20s, and both procedures worked as lung volume reduction procedures. So you can see that the residual volume as percent predicted falls from about 240% to about 190%, and both showed similar reductions, so improvements in the iBode score. In general, numerically, the results favored surgery over valves, but were not statistically significantly different. We had one death in each arm at 12 months, and you can see the individual components. So BMI goes up a bit, FEV1 goes up, breathlessness comes down, walk distance goes up. I say numerically it somewhat favors surgery, but there was no statistically significant difference. And the purpose of the study really was to establish if surgery was better than valves, in the sense that we should abandon this equipoise position. So that's randomized controlled trial data. Finally, looking at using data from the UK Lung Volume Reduction Registry. This looks at 541 patients from 14 centres, and you can see that the survival for the surgery and the valve patients out to about 6 years is the same between arms. So again, this is telling us that the patients that MDTs think are suitable for valves, who have valves, survive as long as the people who MDTs think are suitable for surgery and have surgery. So it's not as much of a comparison as it might appear, but it's suggesting that if you're a patient and your MDT says you should have one treatment or the other treatment, you don't need to feel bad that you're getting that one and not the other one, I suppose. So finally, lung volume reduction procedures produce dramatic benefits, improved breathless quality of life, exercise capacity, and definitely / probably almost certainly survival. There's now specialist commissioning in the NHS, so every appropriate patient in the NHS should be supported to access these. Where there's equipoise between the treatment, the trial data and clinical data suggests that you're getting similar outcomes. So it goes down to either patient preference or to the sort of presumption that valves are a less invasive, short hospital stay, etc. But again, it may be that you're getting a better earlier outcomes with valves because it's a less invasive procedure, but then better long-term outcomes. And that, I think, is something that we're going to need to sort of learn over time from bigger registry data and bigger randomized controlled trials as well. Well, thank you for listening.
Thank you very much, Nick. It was a great overview of what's happening at the moment. We've got lots of questions from the audience, and a lot of them are centered around complications and risks of bronchoscopic lung volume reduction. Could you give us an idea of what are the expected complications that you experience in daily clinical practice?
So and again, it's dominated by pneumothorax. So I mean, obviously, everyone comes out of lung volume reduction surgery with chest drains in, and a proportion of people will have prolonged air leaks and will, need to go home with chest drains. So you have to kind of weigh it up against those. But so that's happening in 20-25% of people post procedure. In a sense, it's a marker that the procedures work, because you only get the pneumothorax where the lung has remodeled, where the target lobe has shrunk down. Beyond that, obviously you're putting a foreign body into the airway, so there is sometimes risks of infection. People sometimes cough the valves up, so they need to be replaced. So, I mean, in a sense, with surgery, once you've had it, you've had it. So you don't go back. I mean, one of the things, obviously, with endobronchial valves is you can, in general, remove them. Most people who are suitable for endobronchial valves are also suitable for surgery, so it's there as a backstop. Infection is not so the ways to reduce the risk of infections are primarily to not select people for the procedure who have very active bronchitis. I mean, we quite, I mean, as a sort of consequence of the way that COPD clinical practice is, we get referred a lot of people who are not particularly well worked up. And it's quite typical that we'll see, this person has bad COPD, is there anything you can do to help? And the thing that we do is actually, sort out their microbiology, often put them on regular azithromycin, and then 6 months, 9 months, a year later, you review things, their airways have quietened down, they feel much better because they've not had a load of exacerbations, they've not had a load of steroid tablets. And at that point, they obviously still have emphysema, they're still breathless, but they're in a much better overall physical condition. So it's important not to put valves into people with a lot of airway infection, because then you run into problems with that. You don't tend to get infection in atelectatic lobe, which I guess is because the lobe that you're targeting, there's just not very much tissue there at all. So it's not inhaling a peanut. It's just you take some emphysematous bullae and you make them small, but there's not very much in there to go on. So that doesn't seem to be a problem particularly.
That's great, because one of the questions that was by Dr. Obadel. It's another question, which is an interesting one. If you have both combination of obstructive and a restrictive defect, would these patients still be suitable for a volume reduction?
Not so. So spirometrically, obviously, if they're restricted because their total lung capacity is high, but their residual volume is very high too, that's fine, because you obviously bring things down. Where people have airflow obstruction and a low lung volume, then no. And that's partly, I think, because as with surgery, obviously what happens with endobronchial valves depends what the remaining lung does. So if the remaining lung is fibrotic, you don't get the sort of the benefit. It doesn't sort of come back into play. It's still fibrotic, and it's a little bit like doing surgery in homogeneous emphysema. You don't change the kind of mean compliance of the lung by taking out. If you just take out, you just make that you have a lung with the same pressure volume relations. It's just a bit smaller.
Okay. A question from Dr. Sultan is, do you have a comparative cost of bronchoscopic volume reduction compared to surgery, or rough idea?
That's an interesting question, because it depends a little bit on what the company thinks is going to work. The valve companies think it will work for them economically. So my impression is that they sort of try to peg the cost of the valves at roughly the cost of surgery.
That's comparable.
So it's a sort of similar cost. Now the NHS cost, I suspect, is substantially lower, because you have a 3-day, you obviously have the procedure, you have a 3-day admission where, unless you have a pneumothorax, you're just sort of sitting there twiddling your thumbs saying, oh, I feel fine, I feel better, hopefully. So it's not, there's not a great deal of work associated with that, as opposed to obviously you go through surgery, most people will come back to high dependency, and so it's a shorter stay and so on. But yeah, I mean, certainly both interventions meet NICE's economic modeling to prove them in terms of the sort of the cost per quality.
Thank you. Question from Professor Paul Bass was asking, what's the failure rate of a bronchoscopic lung volume reduction, presumably referring to lack of improvement of symptoms? And does this need to be centralized as a procedure?
Um, those are obviously two. They're the same question. Um, it's a procedure that is effective if it is done by if you select the right patients and then you do the procedure properly. Now, obviously, there will be a learning curve to that, but you need to have MDTs that are experienced. It must be done at an MDT where there is both interventional pulmonology, surgical expertise, radiological expertise, and the MDT needs to be able to offer valves, it needs to be able to offer surgery, and it needs very much to be able to say no. Your referring team has asked a really great question: are you suitable for one of these procedures? Unfortunately, not. So that people go away at least knowing that they've, that it's not if only they asked, there'd be something else that they could get. So obviously the failure rate depends on how carefully you select people. So the main way it fails is that there's collateral ventilation, so it doesn't work. So it's important to look out for that. There are other kind of technical things to do with learning in terms of putting the right size valves in the right place, and there is a conversion rate. So there are a proportion of people who will get the complication of they start to get chest infections and you have to take the valves out. And hopefully some of those can go on to have sort of surgery. So there is factored into that sort of data about long-term benefit in terms of symptoms, exercise capacity, and the similar kind of survival. Obviously, all of the kind of the complication aspect of it is baked into that too.
Probably final question from Elaine Tay. Is it reasonable for patients who are suitable for both to have bronchoscopic volume reduction first, and if the symptoms progress at a later date, to have surgery, assuming if they're fit?
Well, in a sense, if it works, it works. So, in the ideal patient, say that the right upper lobe is emphysematous, that's your target. You put valves in, it shrinks down to nothing. So there's no additional benefit to kind of removing it. So I think there is always the question of what about the other side, and to some extent as part of the initial MDT workup, you can say, well, both upper lobes are really terrible and both lower lobes are really bad. So we can be pretty confident that at some point down the line, all other things being equal, we'll do the other side. But I think that's something that needs to be, actively considered. So, at 6 months or a year afterwards, it should be as part of the sort of the follow-up process. Okay, what now? And again, the timing of that is a really big question that we don't know the answer to. Should we be doing these things as soon as somebody gets to the point where they find their breathlessness limiting, or should we be waiting right till the end? And we don't know. I mean, I think that's something that I think we do need to do some sort of big pragmatic clinical trial as to whether, if you hit the physiological criteria, should we go when people are MRC3 or MRC4, or you probably want a more sophisticated measure than that, maybe an exercise capacity measure, to sort of see, whether if you do it when someone's 60, then you give them, they can be more fit and active and healthier through their 60s and therefore get less multimorbidity, or alternatively, do you front load the risk, and you'd be better waiting until they're really breathless, and then the improvement you get makes much more difference to their day-to-day life, because they can suddenly do a load of things they couldn't do before.
Yeah, sounds like something for game theorists. Thank you very much, Nick. As always, we have too many questions and not enough time for answers, but don't worry, because next week we've got Professor Lawrence Rumans coming in from Leuven to give the talk on the surgical aspects for lung volume reduction, which remains for me to thank our sponsors, AstraZeneca, Medtronic, and Medela, the Science of Care, and of course, Nick, for your excellent presentation and your leadership internationally on COPD management. So thank you very much for your talk today.
Pleasure.
Bye-bye.